interventions that we've taken advantage of for a very long time. The next level is clinical interventions. That is what I and any nurse, physician, physician assistant, and dentist, that is what we are trained to do. We are not trained historically in the medical model to think about population health. We are trained to say, this patient comes in with this set of complaints, this is the diagnosis, this is the treatment. Follow up with the patient, the treatment did not work, we change the treatment, patient eventually gets better, and they go off. Well, now we know that many of the patients really aren't getting better. We're just checking a box to say that we've done something, and we've got to understand why the patients aren't getting better. And that's why understanding this whole pyramid and getting physicians to understand population health and the environmental impacts or those social determinants, how they impact your patient's ability to execute or comply with the treatment that you recommend. But we've got great therapies, we've got great technologies. Think about Jewish, think about the new technology that comes out for heart disease out of that hospital just around the corner. Think about the new therapies in orthopedic surgery, where people can get their knee replaced 1 or 2 times in their lifetime, and by the time they die in their 80s or 90s, they've had 2 new sets of knees and they've been able to walk their entire life. Whereas other times, at 40 or 45, if you had that level of knee pain, or you would potentially be in a wheelchair for the rest of your life and not be able to be active and have a shorter lifespan. So these medical advances and clinical interventions are extremely helpful, but if we're talking about a population level impact, it's not where you get your biggest bang for the buck. Now, the very top is health education, better known as health fairs, and media campaigns in many circles. And it is a natural response that when you want to help, you are being told on a regular basis that our level of poor health in our community is unsustainable. We will not be competitive as a community. We will continue to get sicker. We will continue to die if we don't do things differently. Most non-clinicians, most non-public health practitioners flock to the top, and that's fine. We need things at the top, but we can't stop there. We can't just have a health fair one Saturday to screen men for prostate cancer and then they walk away. We have to talk about integrating them into systems of care. We have to talk about when we have a health fair and there's a patient who has an abnormal reading, do we immediately make the appointment, or do we trust this person who clearly doesn't know how to navigate the healthcare system, otherwise they wouldn't come to a health fair to get a prostate exam. And do we, I mean, you know, let's just be, I tell the students all the time, if you want to be good at public health, read the newspaper and watch TV. All of the answers are very practical. They're not in the theoretical academic books. That just gives us a framework. But most of the solutions are very practical. So if you start thinking about it from that perspective, you'll recognize and be able to understand how doing that sort of one at a time, one weekend at a time, doesn't help to give us the population impact that we're looking for. So now I have to give my disclaimer, so I'm told this will be on YouTube. I am not saying health fairs should not happen. I am not saying that we should only do the things at the bottom of the pyramid. The pyramid is designed for us to understand how we have the greatest impact. It doesn't pit one approach over the other. And in order for us to be successful in advancing our health, with moving the needle on many of our chronic diseases, we have to understand how to best allocate our resources among the various layers of the pyramid. Okay, so to make that very concrete for you, 2 examples. When we passed the Clean Air or Smoke-Free Workplaces legislation in Louisville Metro, people couldn't smoke anymore. Smoking is an addiction. All right, I recognize what addiction means for people. It is not I quit overnight because the rules have changed. So when we changed the policy that people could not smoke, we had to then go back to the top of the pyramid and provide them the clinical interventions such as nicotine replacement therapy and the counseling such as smoking cessation counseling, often done in groups here in Louisville, for them to be successful non-smokers. All right? Now in the same vein, if I sit here and I say you should use my plate and half of your plate should be fruits and vegetables and you should have X servings of dairy every day and the children should get this, we have to, down at the bottom of the pyramid, create the environments for people to have access to those foods. All right, so these things work in tandem, but in order for us to really move the needle as a community, we've got to think more strategically about how we're allocating our resources across the pyramid. So this is just a snapshot of what we do at the local health department, because that's often a topic of discussion. And I hate to be one of those people that say we don't do that and walk away. It's often we don't do that, this is who is responsible for it, or we're still trying to find a home for that function. And that's okay. We need to understand those things. We need the community. We are servants of the community. I'm a public servant. That's what I do. So if you have an issue or you have a community concern or you have an idea, we're open and receptive to hearing that information. But at the same time, this is our finite list of services. So it may be something that we have to think about strategically. Where does it go? Where does it fit? Is the local health department the best place for it? Should we be partnering with our community health centers, depending on what the particular service is? And all of these slides are available on our website. So now that I've talked about this, just to give people a little bit of numbers to maybe help with some digestion. Maybe indigestion in the wrong way once you get shocked by them. But 1 in 3 adults in Louisville are overweight or obese. 1 in 3. Now, I know some people don't like the BMI. They don't think it's a perfect tool. Shaq, if any of you are basketball fans, kind of messed this up for us in public health a while ago by saying it was irrelevant. He was all muscle. Okay, duly noted. But all of our tests that show all of our things that exactly can barely move down the stairs in that Buick commercial, but all of our watch TV. So all of our tests that tell us that being overweight or obese puts you at risk for things use the BMI. So even if the BMI is inaccurate in terms of classifying you as overweight or obese, it's the actual BMI that's related to an increased risk for heart disease, diabetes, joint disease such as osteoarthritis. So you can go back and forth as to how you want to be classified, but the science is there that a higher BMI is related to more of these chronic diseases. 25% of Louisville Metro adults still smoke, so 1 in 4 still smoke. I think at night at 4th Street Live, it's 4 out of 4. And a couple of other places, but again, 1 out of 4. We are at 24%. 5 years ago, we were at 26%. Let me just tell you, in public health speak, we celebrate that because we look for what we call a 5% relative reduction, not a 5% total reduction. So our goal over a 5-year period would be to reduce that by a 5% relative reduction. So 24% gets us to that goal. 21% was not the goal. However, we had a Healthy People 2010 goal, much more vigilant than that we didn't make, and we're keeping that goal for 2020 because we want to make sure we continue to move in that direction. And then the other things is that we're worse off than most other communities. And if you all are interested, I would encourage you to look at the Robert Wood Johnson Foundation issues a county health rankings report. And many of you may be dismayed to see that in Kentucky, Louisville is not the healthiest community in Kentucky, despite all of our resources. And if you really want to understand or see an illustration of how healthcare doesn't improve population health, look at that report. You'll see we're number 2. 1 is the best. We're number 2 in terms of healthcare access. We are number 118 in social determinants out of 120. So it's really not just about the access to healthcare. So what are we doing over at the health department every day? Well, these are our 5 core priorities, and people will often say, well, what about diabetes, and what about asthma, and what about, well, I think if we get a systematic approach in place, we can plug in disease X, behavior X anywhere and have a methodology or an approach that works. So one of the things that we want to do is we want to continue to create a culture of health and wellness in Louisville Metro. I hear a lot of people talking about wellness. I hear a lot of people talking about prevention in Louisville Metro. That doesn't happen in every community, so you should be applauded for having arrived at that place. Another one is a continued focus on social determinants of health and health equity. We established the Center for Health Equity in 2006 in Louisville Metro, the first of its kind in the nation. And so we recognize the importance of looking at health equity and looking at racial and ethnic differences in health outcomes, as well as geographic differences in health outcomes. We want to make sure we're keeping a focus on that. Strengthening public-private partnerships. Even if they gave me the biggest budget in Metro government, I could not do it alone. Why? Because I don't know all the answers. Why? Because I don't have direct access to all of the people all of the time. And many private organizations, community-based organizations, civic groups have resources to bear. You know how to reach people. You have programs and processes in place. And so creating these public-private partnerships will help us leverage our resources and advance our mission a lot faster. Increased connection between public health and clinical medicine, which is why Leland and I have become such good partners, is really figuring out how do we make sure we have our physician community, our pharmacy community, our nursing community on board with our agenda. And the last thing, which Susan is probably going to stand up and clap for, is an outcomes-based approach, an outcomes-driven approach and data-driven approach to creating programs. And so we want to make sure that we're not just doing things because they feel good, but that we're doing things because the data tells us they're the right things to do. So here's the Mayor's Healthy Hometown Movement, which is the last slide, and then I'll have 2 minutes to take questions. Sorry. But this is where you have the opportunity to join with us. We have 4 focal areas that we're beginning with that tell that our data, meaning what are the behaviors that people have that are causing Louisville to be sick. Those are the things we want to address first. When Mayor's Healthy Hometown Movement first started, it was very centered on sort of physical activity events. We've got the hike, bike, and paddle coming up this Monday. We now do that twice a year, and a host of the hikes out at Jefferson Memorial Forest, et cetera. But we needed to step back and say, hey, wait, if we want to really be a healthy hometown, it's not just the obesity piece of it. We still got 25% of smokers here. So we have to pay attention to tobacco prevention and control. And while there is a tremendous benefit to addressing the health behaviors that lead to chronic disease, we've got to help the people who have chronic diseases already better manage and recognize that having diabetes doesn't mean you eventually go blind, lose your boots before you're in the casket, all of those things. So these are the things that we've expanded to include in our Mayor's Healthy Hometown Movement. We are launching them. We are having launch meetings. The only thing you have to do to be eligible to be a member of our community coalition is to live in Louisville or care about Louisville. And so if you feel free to shoot me an email and I can get you connected to the right groups. And this is where we think if we put our efforts into the Mayor's Healthy Hometown Movement under the new infrastructure that we have, we can get us out of the bottom of the rankings in many of these health conditions, and we can really begin to have more people in our community who can sing the James Brown song, I Feel Good. So I thank you all for the opportunity to address you this morning. I'd be happy to take any questions with the time that the president is going to allocate to me.
Thank you, Dr. Nesbitt.